Morning. How is everyone? We're on to I think it's the third session of the hip now. So yeah, moving into the areas that massage therapists love and the fitness guys love, because they've kind of heard most of these things before. But we're going to teach it from scratch, so as if you've never heard of any of them before, and hopefully you'll get an idea of the kind of layers that we've built up. Just pop my messages on. Here we go. Good morning. Good morning. So we've got a few in today. Neil, how you doing? Tristan, morning. I just imagine you now, the cat on your lap, laptop there, cup of coffee. Got that image in my head. Oh, here we go. Coffee check. Pain au chocolat check. Very good. Well, hopefully we'll be able to dust that off for you this morning, Stevie. And Sarah, good morning. Welcome back again. I'm glad that we can aid your revision every week. It's a nice way to learn. You have to be here. That's the thing. It's that you don't know what you're going to miss out on. You never know. Never know what kind of questions are going to come up. You might have seen this. Quite excited about this actually. I've been putting off teaching level 3 sports massage for quite some time, and the reason why I had is because I had to go through awarding organisations who they give you the materials. Okay, so the national occupational standards are written, and they interpret those national occupational standards and then develop materials. And and then all of the assessments are geared around those materials as well. And the materials and the assessments are on the whole out of date, and they are teaching sports massage in a way that puts you at a disadvantage in the therapy world, because there's lots of things that you're taught, like some of the stuff that we're going to cover today, that just it isn't true, has been disproven, and unfortunately it's still being taught. So there is a way now, thankfully, that I can write a course and get it accredited, and it's my own content. So before I was a bit bound by the awarding organisations, and I couldn't deviate from what they wanted me to deliver. But now I can do my own thing, which is brilliant. It's a company called PD Approval, and they work with the STA, and basically they put the content into our hands, so the people that do the job, and we then interpret the national occupational standards in our way, and it's equally as valid as any other course with any other awarding organisation in terms of the kind of stuff that you'll cover. And so if you know anybody who is interested in sports massage, wants an entry-level qualification, we're starting to run them in Birmingham in April, and then we're just getting dates, hopefully by the end of today, for Liverpool as well. So yeah, it's pretty exciting, and it's weird as well, because I used to teach level 3 sports massage ages ago, like 10 years ago, and I thought, I'd be okay. I'll just use some of my old resources, just tweak them a little bit. and the stuff that we had to teach, my God, I've had to rewrite the whole thing. So yeah, it's been good. It's been really good putting it all together. So yeah, hopefully, if you do know someone, then you can point them in our direction. And we've got the URL there. Racking my brains for ages trying to think of a URL for this, and then that popped up, sportsmassage.education. So it does exactly what it says on the tin. So there you go. That's going to be us from April. So yeah, hopefully we will benefit some of the new sports massage guys coming into the industry. And Learn Anatomy Online is going to be part of the course. So they'll be learning this stuff from scratch, or from the start rather. So that'll be good. Cool. Enough of the sales pitch. Let's have a look at why you are here. Oh, that's not why you're here. You've got a sneak peek of of an electron on bursitis. We'll talk about that in a bit. Right then, so we're going to move on to the onto the muscles and the bursa of the hip, and there we'll probably have to cover the muscles over 3 sessions. So, and we're going to add on some bits from what we did last year. So today we're going to have a look at what we call the rotator cuff of the hip. So all of the small little muscles that surround the greater trochanter, which we've had a look at over the last couple of weeks, the neck and the head of the femur. So around that kind of region, around the joint capsule. So we're going to have a look at those. And also, morning Penny, no problem. You haven't missed much. You've just missed a sales pitch. That's all. Yeah, we're going to be covering those really deep trochanteric muscles, and you might have heard of things called piriformis syndrome, that kind of thing. And again, we've needed to update our terminology because we've kind of ostracized this piriformis muscle. And when you look at the anatomy and you look at the kind of tests that we do and the way that we palpate the region, the way we feel it, it's very, very unlikely that it's just the piriformis that can be causing some of these problems that we often see. So we call it now a deep gluteal syndrome. Okay, so which doesn't really help, but we basically know that something is happening in the deep gluteal region, but we can't be accurate and say it's that particular muscle. There's just no way, unless you have specific nerve conduction tests done and they're ultrasound guided and all that kind of stuff. And to be fair, you don't really need that kind of stuff because the treatment and the exercises that you would do to help this region, it's going to help all of the muscles. So whether you would think you're targeting the piriformis or one of the others, it doesn't really matter because it's going to help anyway. So you don't need to change what you're doing. It's just the explanation is not as accurate as we once thought it was. And how many times have we heard of that? Catherine, Catherine's cat's there. Okay, hold on, ready. That'll drive the cat nuts. There we go. See if he's chasing that. Okay, but we'll have a bit more of that as we go through. Right then. So and Natalie's in as well. Sorry, Natalie, just missed you there. Good morning. Welcome back in. Right. So I just wanted to show you this. So go back a bit. Some of you may have seen this before. I talked to death about this and I presented this at the Therapy Expo. I've done it on a couple of other different conferences as well. But these are very, very common tests that you will see in a clinic environment to assess leg length discrepancy. So you might see someone check your pelvic levels. So putting their hands just either side of the iliac crest, and then they'll push in on the waistline and then they'll go, yeah, that one's a bit higher than that one. Or they may actually physically measure it with a tape measure from the ASIS, which is the bony part on the front of the iliac crest, all the way down to the medial malleolus, which is, if you remember back to the ankle, that's your inside ankle bone. Okay, so from the ASIS down to there, they'll measure that with a tape measure to see how long it is, and then they'll measure from your navel, so your belly button, down to the malleolus as well, and then they'll compare it to the other side to see if there's a difference. And the idea is that the ASIS is a fixed point is a point that, well, yeah, they're both fixed points. But if there's an anterior tilt on on one side compared to the other, then you will pick this up with the measurements because the navel never moves. Okay, so that's the idea with the test. So if there's a discrepancy side to side, then you've got one leg longer than the other. I hear this quite a lot, and it's something called a nocebo. What a nocebo is, if you've never heard of it before, is something where somebody can take something you say very negatively, and it has a negative impact on the prognosis. So basically, they don't think they're going to get any better because of what you've said. Okay, so that's what a nocebo is in its simplest form. And so if you're telling someone they've got one leg longer than the other, they may have all these images in their mind that of what that means to them, and they may change the way they move, and they may be kind of lumbered with this issue for a while, and they're going to believe us as well, because that's what a number of people say to them, and they go, yep, that's the case. There are so many different factors that can give you a longer leg. The only way you are going to know for sure is if you have an X-ray and they physically measure it on an X-ray. Okay, that is the only way because of this. So if we have a look at this, this was a study done by a chap called Priest. I think it was back in 2008 at Salford University. So with a chap called Lee Harrington, who deals a lot with usually with knees. So what they did was they looked at the angles of inclination of the pelvis. So these are all the things that we've been talking about over the last couple of weeks, the ASIS and the PSIS, and you might have been on courses where you measure the difference between these. So we've got the PSIS up here and then the ASIS there. And what they did, they took these cadavers and they put them in a neutral pelvis. So the pelvis was in the same position every time they measured it. And then they measured the ASIS and PSIS differences. And normally in clinic, if there is a tilt, then we would say that side is anteriorly tilted or posteriorly tilted, or whatever it is. Sorry, my phone's going off again. I'm just going to turn that off. I was sure it was on silent. Apologies. I'm going to get Siri going as well now. Oh, it's not turning off. Come on. Oh, it's not liking that. Apologies. I'll try and sort that out in a minute. So you measure this tilt, but the problem is these were in standard cadavers, and they measured the difference. And the difference can sometimes be between 0 and 23 degrees. And that's from side to side as well. So somebody can have an absolutely level pelvis, so the ASIS and PSIS are absolutely in line, and sometimes it's tilted, sometimes it's back. They're very persistent, and sometimes it's back. So there is no standardized measurement because everybody is different, and it varies from 0 to 23 degrees. So how do you know that you're measuring an anatomical variation, or whether somebody actually has a rotated pelvis? And you can't tell. There is no way you can tell. And the other thing which is interesting is there can be a 16 millimeter difference in innominate height. So when you do that squeeze in test and you push down on the iliac crest, it can be higher on one side than the other, just literally because the innominate bones, so the pelvic bones, are bigger on one side compared to the other. So it looks as if they're tilted, but actually that is them. Okay, so you're detecting something that is normal for them, and then you try and change it by doing all these techniques and exercises, but it's the bones, and you can't change those bones. You can't change that bony structure. So there's a lot of things like this in anatomy where, and it's coming to light, especially over the last 10 years. I was taught to do this in my osteopathy degree, and now I don't do it at all because there's no point. There is literally no point. So the name of the researcher was called Priest. So it's Preece, Priest. And I'm pretty sure it was 2008. And the paper was something like anatomical variation or anatomical morphology variation, something like that. I'll see if I can find it and pop it in the group. These are the problems that we face, and it's perpetuating these myths that the body out of alignment causes pain, because we know that that is very unlikely to be the case. And all of these things to do with the anatomy and the differences in the anatomy just show that the measurements we use aren't valid. So they don't do what they say they do. And if the measurements aren't valid, then our tests are invalid. Okay, so we can't, we just literally can't use them. But it's still being taught at universities. It's very frustrating. Okay, enough of my rant. Let's go on. Okay, so bursa. So we're going to have a look at the bursa and the muscles around the hip. And this is a really nice picture because you've got, you can see pretty much all of the bursa here. They aren't purple in real life, just to differentiate between the structures. But what these are, they're like it's a fluid-filled sac basically, and the name bursa means purse. Okay, so it's like having a fluid-filled purse. Okay, so you've got these bursa all around the structures in the hip, and usually they are around the greater trochanter. Okay, because it's stuff that rubs against bone. That's usually where a bursa is. Okay, so if you have a look here, so we've got big glute muscle there, and then there's a bursa just there because the greater trochanter will come out to there. Then there's another one there and another one there. We don't see these in cadavers. So when you look at the anatomy videos, you won't see these because they dry up. Okay, so when you're dead, they just dry up. They are filled with fluid, and when you if you have a fall or you irritate it by keep on lying on it, especially in the hip, then you can have something called a bursitis, which is an inflammation of the bursa. And well, you've just had a sneak peek of that. Oh, thanks, Tristan. Tristan's just found that paper, so thank you very much. So you can go and have a look at that. It's a good study. There's loads like that for all over the body. And then we've got this one here, so the iliopsoas bursa. So we've kind of had a look at this area last week because we looked at the inguinal ligament, and we saw that the psoas and the iliacus came through this area and then attaches onto that lesser trochanter just down there. So if you imagine the muscle lying over the top of this bursa, if there was nothing in the way, it would just be rubbing over the hip capsule, and it would cause friction between those two surfaces. So what the bursa does is it provides a friction-free surface so that things can glide across each other without irritating them, basically. Okay, so, and you can grow bursa in different areas. So if you have a look at this, talking about growing bursa, I had a patient with one of these once, and in fact two. He had him on both elbows. He was an oncologist who was on his desk, just leaning his elbows all the time, and he was doing a lot of work, sedentary, just leaning on his elbows, and both of his bursa in his elbow came up like that. Okay, they were absolutely huge. So this is a bursitis. Okay, so that there's a bursa in the elbow called the olecranon bursa, and that is what they look like. So it can, obviously, because of the tissue in the hip, they're not as pronounced as this, but you can still see some swelling around the bursa in the hip. So the iliopectineal bursa, which is where the one you just saw on the front of the hip, that one's fairly superficial. So sometimes you might see that one a bit puffy. Okay, possibly on the side of the hip as well. But that's basically what they look like. So if they're quite superficial, they'll come up like that. You might have heard of something called housemaid's knee. So if you lean on your knee over the bursas in the knee, then that can come up, and we talked about that when we did the knee. So what do? So they alleviate friction in some joints or between different anatomical structures, and it's usually between something and the bone. Okay, so obviously the bone is really tough. The something, whether it's ligament or tendon or muscle, is usually soft tissue. So if we've got those things rubbing against each other, the bone is going to win. So we need something in between to protect the soft tissue against that bone. So hence why bursa are there. So they look a bit like a joint capsule, but they don't have synovial fluid in. They've got this thick fibrous outer layer, and they're filled with bursal fluid. So it's very similar to synovial fluid, but slightly different. And what they do is they cushion the movement around areas where there is a lot of activity. Okay, so obviously in hips, you're moving your hips. In the shoulders, there's loads of bursa there. In the knee, so all around the joints, usually that's where you'll find these bursa. So sometimes when you're poking and prodding on things and bits hurt, it may be a bursa that's causing the issue. Penny, you've just asked a question now. I don't know what it relates to. Sorry, if you pop a little bit on the front of that, and then I'll try and answer that. Natalie got a great picture of housemaid's knee from a client. Didn't see her those months, but I asked for a picture. Yeah, I could check it. Yeah, that'd be great. Yeah, because they come up really, really big. And there is a video of someone having a bursa aspirated. So what they do is they put a needle in and then draw the fluid out. And I'm sure I posted it in the group a little while ago, actually. So yeah, have a look for aspiration if you fancy doing that. Let me just show you how that is spelt. So it's spelt like that, aspiration. So yeah, if you want to have a look at an aspiration of a bursa, then just Google it. There's some out there. What sort of symptom? Right, cool. So what sort of symptoms would you expect if a bursa was inflamed? Usually it's because with inflammation, it's usually worse in the morning, and then as you move, you tend to get rid of some of the bursal fluid as you go through the day. So it starts to calm down as you get through the day. But depending on where it is, it will restrict some joint movements. So in the elbow there, it won't really affect anything because you can still straighten your elbow. But around the knee, yeah, it depends on where it is there as well. If it's around the back of the knee, it can stop you flexing the knee. But in the shoulder, there's a bursa there that's very, very close to the acromion, which is the top part of your scapula, and your humerus fits underneath, and there's a bursa in between. If that gets inflamed, it fills the space. So then it's really hard to lift your shoulder up. And you usually have something called a painful arc, where the first bit of the movement is okay. The middle part is ow, 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 ow. But then when you get to the top part, if you can get to the top part of the movement, the humerus drops down, so it gives the bursa space, and then the top part of the movement is okay as well. And that's called the painful arc. And so you'd usually get things like that, or sore to touch. So if you pushed on that elbow, then usually it's quite tender. Okay, but the problem is around the hip. Unless they've fallen on it or they've lay on it for a long period of time, like if they've been in hospital or something, it's more likely to be a glute tendon or a deep glute muscle than it is the bursa. Bursa are usually irritated by impact or friction, irritation, friction, compression over time. Okay, you can get compression though with certain stretches. So this is why you don't really want to be stretching a gluteal tendinopathy, because if you stretch it, it squishes the bursa and it irritates the tendon. So stretching is not great for tendinopathies. Yeah, so it's yeah. I like aspiration. Okay, cool. They wouldn't touch it. Just said to stop running 6 days a week, and then it went down. Okay, cool. Yeah, I mean they do. Yeah, so they do often just resolve on their own. Where does the fluid come from? It comes from the inner lining of the bursa. So it because it's irritated, it puts more fluid in because it thinks that that's what it needs. Where sometimes that's useful because it stops you doing stuff, but sometimes it's not, and it delays the recovery. So, but yeah, if we can get things moving, that's better. Interesting about the shoulder, as these are usually the ones that get diagnosed with frozen shoulders. Yeah, I think there's a really good article that Adam Meekins wrote about frozen shoulders, and I get really annoyed with clinicians who think things are frozen when people can lift their arm up above their head. For me, that's not a frozen shoulder. Yeah, it's just bizarre. What I think is quite, in some ways, quite a lazy diagnosis. So yeah, there are certain things that you can do to prove it's not frozen. Cool, some good questions there. So Stevie has had one on his elbow. A lot of heat, pain, inflammation, and you can easily feel the fluid. Yeah, it's kind of like, it's a bit jelly-like. Yeah, it's not like water. It's quite the viscosity is quite thick. Yeah, thicker than you think. So if you have a look at the aspiration videos, then you'll see that it's like a kind of jelly type liquid. Cool, good. Okay, so these are the bursa around the hip. I'm going to just move me there. So this is the glute max has been taken back. So this is the edge of the greater trochanter just there. So there's a trochanteric bursa. And yeah, this is the greater trochanter just underneath. So this is often misdiagnosed as well, especially with usually GPs. So somebody will come in with lateral hip pain, so pain on the outside of their hip, and they will say, "Oh yeah, it's a bursa," but usually, yeah, unless they've fallen on it, it's usually a gluteal tendinopathy. Okay, so which you would deal with in a different way. We need to load that tendon rather than rest it. So you'll just make me smaller a bit so you can see everything. So this is from a study, morphology of the bursa associated with the greater trochanter of the femur. It's easy for me to say. Back in 2008 as well. And so this looked at 106, this looked at 18 cadavers, I think, at that? Yeah, 18 cadavers. And a total of 106 bursa were identified in 10 different locations. So it's not just as simple as there is a greater trochanteric bursa. Yeah, there are loads, and you grow them. Yeah, in response to what you do. So your bursa will develop depending on what your activity levels are. On average, there are 6 bursas per hip. 4 bursa were present beneath the glute max and the fascia lata. So we'll talk about those as we bring in the muscles, including those normally thought as the trochanteric bursa and the gluteofemoral bursa. Okay, so there's a lot more than we think. It's a lot more complicated than we try to simplify it. 2 bursa beneath the tendon of the glute medius muscle, so the anterior at the front, subgluteus, so underneath the gluteus medius, and then the piriformis, so posterior subgluteus medius again, on the back of it rather than the front of it. So it's kind of sandwiched between bursa. So the majority of cases, a single bursa was located deep to the glute minimus. Trying to read these around the camera. Although 2 different bursa were identified, so the subgluteus minimus bursa and then a secondary subgluteus minimus bursa. Okay, so it's basically just littered with them. It's not as simple as there's just one on the outside of the hip. So again, we used to do a clinical test where you would put pressure, so you'd push on the greater trochanter to see if it was painful, and if it was, we go, that's a greater trochanteric bursitis. And we know now that there are lots of other things that it could be. So this is a nice image of what was just described. So we've got all of these different levels of bursa in between each of the tendons. Okay, so there's the piriformis tendon, there's glute min, and then in between each one, we've got these bursa just in there to stop them rubbing against each other. Okay, because obviously they're not fanned out like that in real life. They're all quite close together. And then you've got this subgluteus maximus bursa. So there's your glute max, there's your greater trochanter. So that one is what we would usually call the trochanteric bursa. Yeah, is that one there? But there are loads of others too. All right, so worth thinking about. You can, they're very, very thin. So they're a lot thinner than you think. And when you, if you have a look on some of the images on ultrasound, so if you just Google bursa on ultrasound, you literally can't see it. And if you can't see it, that's good, because you're not supposed to see it. It's supposed to be a very, very thin capsule with a tiny amount of fluid in. So if you can see it and you can see this lump with fluid in it, then we know that there's a bursitis because it's got additional fluid than what it should have. Okay? So yeah, they should be very, very thin. Cool. And then we've got the iliopsoas bursa. This is also known as the iliopectineal or iliofemoral. So again, if you think about what we've learned over the last few weeks, ilio is to do with the ilium, and then pectineal is the pectineus muscle. We talked about that when we looked at the, bizarrely, when we looked at the knee. We talked a little bit about the adductor muscles, and then iliofemoral, so between the ilium and the femur. Yeah, so it's around that kind of region. So you can see it lying there, and then your iliacus and your psoas muscle will run over the top of that. So it'll provide some protection underneath. Okay. Is TFL issue more likely to be a bursal issue, do you think? It's a good question, Stevie. Yeah, possibly. Yeah, I think it shouldn't be. You shouldn't discard it as a possible hypothesis. Yeah, it's one of those where if you're doing a lot of strengthening work and things just aren't improving, then maybe it is a bursal issue, and doing some of the movements are aggravating the bursa. Potentially, but you'd never know unless you image it, and usually they calm down after about 5-6 weeks. So it's a bit annoying for a bit, but then they'll usually settle down. Do you know what? Weirdly, my brain works exactly the same way. Whenever I hear TFL, I always think Transport for London as well. The tube network is causing my hip pain. Okay, let's have a look at this. Yeah, so then we've got these bursts around the back. Okay, so and the one that usually gets irritated is this one. So the ischial bursa. So this is underneath glute max, and on top of the hamstrings where they insert on the ischial tuberosity. So usually that one's an issue, but only again from irritating it from sitting on it for too long, or banging on your bum. Okay, so if you bang on your bum bones, that can then irritate that bursa. And then these are the other ones that we saw earlier. So there are loads of them. There are loads of muscles as well, and hopefully we'll get through it. Yeah, we've got plenty of time. Okay, so we've got 10 muscles in the gluteal region. Okay, 10. So there's quite a few to go through. We're going to concentrate just on these deep posterior muscles today. And again, there's, from what I was talking about earlier, it can't be piriformis syndrome. Well, it could be, but you can't say for sure. Yeah, so because there's so many in that region that you're never going to be able to tell. So we're going to have a look at these deep posterior muscles, so the rotator cuff of the hip. Then we're going to have a look at your 3 big glutes, and we'll do that next week, along with the Transport for London, as long as a tensor fasciae lata. We're going to talk about that muscle as well, and then we're going to have a look at the adductors of the hip, but that will be next week, and then we'll go on to the pelvic floor muscles. Okay, so we'll have a look at those as well as a separate session. Cool. So deep posterior muscles. We're going to have a first of all look at the gemelli muscles. So gemelli comes from Gemini, which means twins. Okay, so they come from a similar location and they have the same action, so they work together. Okay, so that's why they're called gemelli. They're like 2 twins. So we're going to have a look at those first. So this is a picture of them. So if we just orientate ourselves with the images, and then it will help when we look at the videos. So that's your greater sciatic notch, and that is your ischial spine. Yeah. So if you remember that little pokey out bit which divided the lesser notch, which is that one there, with the greater notch, which is that one there. So it attaches around that region and then comes all the way over here. And then this bit here was that intertrochanteric crest. So if you remember, on the front it was a line, on the back it's a crest. And my thinking behind why this is a crest, so it's more raised, is because of all the muscles that attach into it. And you'll see how many in a second. So that's your first one. So we've got a gemelli or gemellus superior. So that means it's up above. And then you'll never guess what. There is a gemelli, press the button, inferior. Okay, so you've got a superior one and an inferior one, and they're Gemini, they're twins. So the superior is from around about there onto here, and the inferior is from around about there. So on that kind of ischial spine area again, and then onto the same place. So they both come from the same area, okay, and they both do the same thing. So if you think about where they attach from and to, when they contract, so when the muscle fibers get closer together, the only thing that they can do is bring about lateral rotation. Okay, obviously there's a stability element if you're not physically externally rotating your hips. So with walking, for example, they would work isometrically, so they would contract without moving to stabilize your hip joint. Yeah, so they don't only contract all the time, they can control movements as well. So that isometric is really important. So yeah, that's where they go from and to, and one above, one below. So let's have a look at those on the videos. Just switch to here. Okay, cool. There's a lot going on. Right, let me just get rid of that ticker. There we go. So right at the top here, and we'll cover these in a second. We'll kind of add them on. So we're going to introduce some just so you can orientate where things are. But that muscle there is called piriformis. We're going to talk about that in a sec. Then you've got obturator internus. So there's an obturator muscle, obturator externus, and then your ischial tuberosity down here. Okay, so obviously we've not covered any of those muscles yet, but it's useful to know what they are so that when you have a look at the gemelli, you can see where they are in relation. Okay, this is your sacrotuberous ligament. Okay, so just labeled everything there for you. So try to add more labels on to these videos so that you can pause them and get your head into where things are. Okay, so let's have a look as we add some things on. And there is your superior and inferior. Okay, so they look like one muscle. Yeah, so that and that all look like one muscle. I mean, that's obviously clearly a separate muscle up there. So that's your piriformis muscle. But your gemelli muscles envelop this muscle here. So if I just take that back a second, we have a look at this. So we've got obturator internus, and then there's your gemelli. Okay, so it's kind of sandwiched the obturator muscles. Both the internus and externus go around that area, but they're really, really close, and that's why they're called Gemini or gemelli muscles, because they do the same thing and they come from roughly the same kind of place. So it's around that ischial spine area, and obviously everybody's different. So on this video it's a little bit lower. So there's your inferior, there's your superior. So around here, ischial spine, that kind of region, and then onto that intertrochanteric crest. Okay, so there are 2 of your 6 deep hip rotators. So if you have a look how close that is to piriformis, and you're palpating, this isn't obviously real life because there are glute muscles on top of these. So you've got glute minimus, glute medius, glute maximus, all on top of these deep posterior muscles. So if you think that you can palpate piriformis accurately, then I'm afraid you're probably mistaken. So yeah, it's very, very difficult to know exactly where you are. You will be affecting something around this region with whatever it is that you do in terms of treatment. Okay, so those are your gemelli muscles. So you've got inferior and superior. And then we've just seen these. We'll have a sneak peek of these. So these are the obturator muscles. And if you remember from previously, there's that obturator foramen, so that hole. Let me just grab my pelvis. I have to keep them locked away in a box because I've got 2 dogs, and you know what dogs are like with bones. I don't fancy them wandering around the house with this. So that there is your obturator foramen. Okay, so foramen is a hole, but remember it's not a hole in real life. There is a membrane on there. Okay, and the membrane is where this muscle attaches onto. It's very similar to the interosseous membrane in the ankle and the foot, so between the tibia and the fibula. So we've got this really tough fibrous membrane that fills that hole that the muscles then attach onto. Okay, so if you have a look here, this one is called yeah this one is called internus because it's on the inside of the pelvis. Okay, so that's the way to remember it. And if you have a look, there's your ischial spine. So it sits on the inside of your pelvis and then wraps underneath your ischial spine through the lesser sciatic notch. Okay, there's the greater one just there. That's the lesser there. And look where it attaches. Similar kind of place to the gemelli, similar kind of place to the piriformis. Okay, so very, very close. And then if we have a look at the next one, yeah, you just got dirty minds, you two. Okay, and then this one here, this is the obturator externus. So this is on the outside of the pelvis. Okay, so internus is on the inside. So if we have a look here, internus is going to be in there, externus is on this side. Yeah, so internus in there, externus here. So it makes sense where they are. And then if you have a look at the attachment point, it's up on that intertrochanteric crest again. Okay, so that trochanteric fossa of the femur, there's a little dip in the around the crest. And again, very close to the piriformis and your gemelli muscles. So all attaching into that similar area. So let's have a look at those. Just get rid of that one. So this is obturator externus, so the one that's on the outside. So orientation, there's your sacrum. Obviously half of the pelvis has been removed so that you can see the muscles. There's your greater trochanter, there's your lesser. So this is a front view of a right hip. That's your hip capsule. Those are your sitting bones, so that's your ischial tuberosity, and then your pubis will be at the front just there. Okay, so let's have a look at this. So this is externus, so sitting on the outside. Oh, that went quick, didn't it? Hold on. Okay, perfect. So you've got your hip capsule here. So these are all the ligaments we looked at last week. There's your pubis, and this is the inferior ramus of the pubis. So if you remember, ramus means branch, inferior means below. So this is coming off of the pubis and below it. That there is your muscle that is kind of attaching what you would think is thin air because there's just a hole there, the foramen, but it's because it's filled with a membrane, it's attached to that membrane. Okay, just going to scroll through there. So that's its attachment point, so the obturator membrane, and then it kind of sweeps underneath the hip to pop out round the back, just there. Okay, so that's the attachment point just there. And you can see the intertrochanteric crest, and there's like a little dip just in there. So that's the obturator externus. So underneath the hip joint onto the intertrochanteric crest. So you can see it's coming from the outside of the pelvis, underneath the hip, sweeping round onto the back of the greater trochanter. Okay, so that's where that muscle goes to. I think that's that one, yeah. And then if we have a look at internus, so just give you an orientation again. So this is your sacrum, that is your sacrospinous ligament. That one there will be your sacrotuberous ligament, going from the sacrum to the ischial tuberosity. That there is your pubis. Okay, so that's the front part of your pelvis there. So we're looking at the inside of the pelvis, and then that there, that shouldn't say greater trochanter. That should say obturator membrane. Okay, must have been tired when I put these together. Greater trochanter's through that. It's on the other side. That's your obturator membrane just there. Okay, so let's have a look at this as we go through. Just take that back a little bit. Try and pause it in the right place. Pause, go. Okay, cool. So that's more like it. So this is the inside of the obturator membrane, just there. Okay, so they're on the pelvis side. Sacrotuberous ligament, sacrospinous ligament, just there. Okay, let's have a look as we layer it on. There's the muscle. So that's your obturator internus. Okay, huge muscle fills all of that space. Yeah, massive, massive muscle. This is on the internal part of the obturator foramen. And if you see here, it's going through, so that's your sacrotuberous ligament. There's your sacrospinous ligament, and that is the lesser sciatic notch. Okay, so it's going through that notch to get around to the back. So through that hole, so that's where it attaches to, and then it's going through there. There we go. So through that gap, and then it goes kind of 90-degree turn, and then onto that intertrochanteric crest area again. So if you remember, this is the kind of image that we had. Just pause that right at the end a second. So that's the kind of image we had at the beginning when we were looking at the gemelli muscles. So you had the gemelli superior and inferior envelop this muscle, or these group of muscles. Yeah, so they're a little bit more superficial. So again, I challenge you to be able to palpate one individually. So that's 1, 2, 3, and then we had another, the gemelli muscles, 4, 5. So those are 5 deep hip rotator muscles so far that we've had a look at. We haven't had a look at the piriformis properly, so let's have a look at that one. There we go. Okay, so piriformis, some people have heard this one, and it basically, the name comes from form of a pear. Okay, so it's got quite a large muscle body, and then it goes into a thinner tendon at the end. So it is probably one of the chunkiest deep hip rotator muscles, and it fills this greater sciatic notch area. So let's just have a look at that. There we go. This is a good view of the front, because we often don't appreciate that it actually starts on the front of the sacrum, and then it will travel through the greater sciatic notch onto the intertrochanteric crest, so that top part of the greater trochanter. Okay? Exactly the same action as all of the other muscles we've just looked at. So let's have a look at piriformis. This is everyone's favourite. Okay, so if we come around to the front, just pause that there, get me out of the way. So you've got your greater trochanter just there, lesser just there, iliac crest, and then the sacrum at the front. So we're going to be focusing on this area here. This is where the muscle is going to pop up. And there it is. So on the anterior part of the sacrum, and it will go through the greater sciatic notch. And we often think of this as a problem because of the sciatic nerve. And when we get to the nerves, I'll show you some variations of the arrangement of those structures as well. So right from the front, all the way through. So that's the anterior part of the sacrum just there, and then through that greater sciatic notch, and then all the way through onto the back of the greater trochanter, just there. Okay, so it hugs that top line and then all the way through here. Okay, onto that intertrochanteric crest again. Yeah, so that, and again, another one attaching into that region. Okay, last one, and then we are done for the day. Okay, quadratus femoris. So quadratus means like a quadrangle, so like a kind of rectangle shape, and you can see that it is rectangular, and it attaches onto your femur. Okay, so quadrate tubercle of the femur on the intertrochanteric ridge. So another muscle that attaches onto here, and I actually think that this one is usually one of the issues. So piriformis, yep, definitely is involved in some things, but I think quadratus femoris doesn't get enough press. Okay. It's a good question, Sarah. I don't really know. Why did piriformis become such a popular muscle in therapy if so many other muscles around the area? I think what happens is when you learn at level 2, level 3, you don't actually learn that there are more hip rotator muscles. You learn piriformis, and that's pretty much it. And you learn the glutes. And because of its relationship with the sciatic nerve, maybe because it's so close. But when you delve a little bit deeper and you're like, oh, I didn't know there were another 5 muscles that externally rotate at the hip. And they all attach into the same place as piriformis. So it's only when you learn a little bit deeper that you understand that there are these things, and that's the reason, I think. That's what I would surmise. Right then, so last one, quadratus femoris. Here we go. So greater trochanter, again, lesser trochanter just here. So those are going to be important, especially this one when we get to the psoas and iliacus. And let's have a look at where quadratus femoris is. There it is. Okay, so this one is fairly superficial. It's got quite a broad contact and all the way along that intertrochanteric crest. And again, if you imagine that muscle contracting, then we know that it's going to externally rotate the hip. Okay, so on that ischial tuberosity, and then intertrochanteric crest just there. Okay, there we go. So you've got obturator externus is underneath quadratus femoris. So quadratus femoris is the most superficial. And then you've got internus and then your gemelli muscles here. Yeah, so look at all of that, all those 6 muscles attaching on that intertrochanteric crest. So if you're palpating, you're feeling along that posterior aspect of the greater trochanter, and you're feeling along that line, and those are the areas that are tender, it can be any one of those. So if it's obviously, if it's a bit more inferior, then it may be the quadratus femoris. Yeah, but if it's in the middle kind of area, then it could be any of them, to be honest. Yeah, it's this is good. I was told because it sits so close on top of the sciatic nerve and it squashes it when it's tense. Wait until we get to the nerves. Yeah, because I'll give you a bit more detail, which will give you some other things to think about with that. Cool. So that's where it goes. So all of those muscles are lateral rotators, but again, they don't just externally rotate or laterally rotate. They also stabilize the hip during gait. So obviously, we don't want our hip externally rotating all the time. When you take a step, they will provide isometric contractions to control the hip movement as well. Okay, so just stuff to think about. Cool. Done for another session. Cool. Oh, I didn't mean to put that one on, sorry, as a subliminal plug. Cool. So yeah, we're nearly getting through the muscles. So that was 6 of them. We're going to have a look at some of the muscles on the front of the thigh, which bring you up into hip flexion, and the adductors as well in a bit more detail, and where they attach around that region as well. So there's a lot going on in the hip, which you would imagine because it's a weight-bearing joint, and there's quite a lot going on there. You're very welcome. Thank you very much for joining us. We're getting more and more people join us live, which is brilliant because we get loads of questions then, which just kind of helps everybody else. So feel free to ask questions, and yeah, because somebody else might be thinking it, and then you say it, so that's good. You're very welcome. I will see you next Monday at 10 o'clock. Cheers.